So the next session features a topic which unites us all in this rollercoaster year of 2020, change. We are delighted to welcome Professor Anita MacDonald, OBE, to introduce and lead this section and introduce all the other dietitians who have contributed. Most of you will know Professor Anita MacDonald from her involvement in inherited metabolic disorders, which has spanned almost all her working life, over 40 years. She is a consultant dietitian in IMD at Birmingham Children's Hospital and an honorary professor in dietetics at Plymouth University. Although she semi-retired 3 years ago, she is even more involved in PKU work, concentrating solely on this group, as well as doing some volunteer work for the NSPKU. Professor Anita MacDonald obtained her PhD in PKU in 1999 and has directly cared for over 300 patients with PKU. She has always been involved in research, currently supervising 4 PhD students and 4 master's students and lecturing worldwide on PKU. She has around 400 publications, many are research publications on PKU. She is a member of the European PKU Guidelines Group, which is aiming to standardise PKU care across Europe. She is a member of ESPKU Scientific Advisory Committee and a member of the UK NSPKU Medical Advisory Panel, as well as chair of the European Expert Nutrition Panel in PKU. As we can all imagine, there is still no time for painting or watching the world go by. I will hand over now. Thank you very much.
Rachel, thank you very much indeed for the kind introduction. It's certainly my pleasure to introduce this session. What we have witnessed in recent times was unthinkable 12 months ago. How has COVID affected your working life? Is there anything that we can learn from this experience? I will be introducing a series of speakers shortly to discuss their individual COVID experiences. We've got 5 wonderful speakers this morning, and all will be presenting about COVID-19. The first speaker will be Camille Newby, and Camille, all of you know, she's worked in the NHS for the past 14 years, working within both adult and paediatric medicine. She now specialises in inherited metabolic disease and ketogenic diet therapy, and is the Southwest Regional Dietetic Lead for Inherited Metabolic Diseases. The second speaker following Camille will be Anne Grimsley. Anne is the lead specialist paediatric IMD dietitian working for the Belfast Health and Social Care Trust in Northern Ireland. She has worked closely with the metabolic multidisciplinary team there for over 20 years, sharing a dedication to improve the quality of life for children and families with metabolic diseases. Our third speaker, this is a real treat, it's Kathleen Ross. Kathleen's just retired after 40 years service of dietetics, almost all in paediatric dietetics. Now, when Kathleen started working in Aberdeen, she was single-handed, as most dietitians were in those days. She's now proud to leave a department that is 10 strong. She's always had an interest in managing children who live a long way from the hospital, and has always had a big interest in developing managed clinical networks across Scotland for her most complex patients. Our number 4 speaker is Louise Robertson, and Louise has been qualified as a dietitian now for over 15 years, specialising in metabolic disease since 2008. And this is when she set up the adult services at the University Hospital in Birmingham. And Louise is on the BIMDG Dietitians Group Committee. She's also on the Medical Advisory Panel for the Galactosemia Support Group, as well as also working for the Galactosemia Support Group. And finally, but not least, we introduce Sarah Bailey. Sarah has worked as a dietitian in Cardiff in a variety of adult clinical specialties for the past 16 years, alongside an operational lead role for the last 10 years. She's developed a keen interest in inherited metabolic disorders while working in emergency medical admissions, and she's moved to work in a newly established All Wales Adult IMD service 4 years ago, and currently Sarah's studying for a master's in advanced clinical practice at Cardiff University. Well, welcome to all our wonderful speakers. Thank you.
Thank you, Anita, for that lovely introduction, and thank you, VitaFlow, for inviting me here to speak today. I'm going to be talking today about adapting services during the time of COVID-19. I'll start off by giving a short overview of the Southwest Metabolic Service, talk about video clinics using the platform Attend Anywhere, virtual home visits, virtual patient events. I'll talk about educational and supportive videos that we have produced, and I'll also discuss any issues or lessons that I have learned along the way. So Bristol Royal Hospital for Children is a tertiary care centre for the southwest of England. We have shared care with 10 hospitals across the southwest, and we do visiting MDT outreach clinics to 5 of those hospitals in Bath, Taunton, Exeter, Plymouth, and Truro. Throughout the year, we usually do 18 clinics where we attend the hospitals in person, but because of COVID-19, we haven't been able to go to all of those clinics, all of those scheduled clinics. So we've had to find ways to adapt, and that brought in using video consultations. So some of you may remember that back in 2018, I presented at this meeting about using video consultations as a tool to enhance my service. Due to a lot of red tape and barriers, I had not been able to progress any further in making this happen until COVID-19. Within about 2 weeks of going into lockdown, we started to use virtual clinics using the package Attend Anywhere. To make this happen safely, there were a few issues to consider. Training. So I didn't get much training on how to use the Attend Anywhere package. I was sent a link to a 5-minute video on YouTube, and that was all I was given. So the first time I was doing an Attend Anywhere clinic, I was actually quite nervous because I wasn't too sure how it was going to work. We also need to consider the equipment that you have. So if you are shielding and needing to work from home, or if you were asked to work from home to enable social distancing within the offices, did you have a laptop to do this and a headset? And then also, do the families have the same equipment, have the equipment and the technology to be able to access the Attend Anywhere clinics? We have had some families that have said they don't want to use video clinics, and they have refused to do so, so we had to revert to phone reviews. So I think it's important to consider certain issues such as IT skills of the clinician and the parents, the cost of the equipment that is needed, parental access to personal technology, and if they have efficient broadband. This is important because some of the remote areas in Cornwall have quite poor reception, so it was hard to be able to make good connections sometimes. And also you will miss some subtle social interactions between families and the clinicians. Also to note, we have been able to start doing Saturday clinics as a waiting list initiative because due to COVID-19, we did develop a backlog of patients that were not seen, or that we had to prioritize other patients over some reviews. So we are doing Saturday clinics now. I don't know for how long this will go on, but at the moment, that is what our service is providing. So I think it's important to note that video clinics are not a replacement for face-to-face clinics. I feel if used appropriately, they can enhance a service. So as I stated before, the Southwest, we travel around doing regional clinics. I think we will still go to at least 18 regional clinics a year, but maybe be able to increase our contacts with the regional patients by providing video clinics in between face-to-face clinics. And by doing so, maybe what we will do is we will have face-to-face. If you see it, for example, if we see a patient twice a year, a standard every 6 months review, maybe one of those reviews will be in a face-to-face clinic and another one will be in a virtual clinic. This should hopefully increase our productivity and increase our contact with patients around the region. Also, I have found that I have been able to have more contact with patients around the region by being able to provide more training and education to families, and it has helped me provide a more equitable service across the southwest of England. So, for example, video clinics have allowed me to replace telephone consultations at the time of weaning or the introduction of the second stage protein substitute. Ideally, at these times, it would be great to be able to go and do home visits or bring patients into clinic to be able to so we can do those things in person. But because of the large geographical area that we cover, we are quite unable to do that because it's quite hard to expect some families just to travel all the way up from Cornwall to Bristol for 3 to 4 hours in a car, and that's both ways, to just go over the introduction of the second stage protein substitute. So video clinics have allowed us to do virtual home visits, and these have been very beneficial. The share screen function has been really helpful because it allows you to show them websites and online resources. For example, here the NSPKU website, when looking at their low protein and exchange fruits and vegetables information. So it allows you to look at those together. And also sometimes we will develop our own PowerPoint slide presentations to enhance education during these home visits. And also, one thing that I haven't been able to do until now is see parents giving the second stage protein substitute. So it's really important that we are able to do this because it helps support families through these challenging times. And on the first time I did a virtual home visit for weaning, I actually set up the camera in my kitchen so people could see my scales, they could see what cooking equipment I had, and they felt they could show me what they had, and it developed around that area as well. So one thing that families have been saying is that they really do miss all the patient events that we put on. So we have, as a service, tried to put on a few events. We held a virtual cooking event with Chef Neil back in May, which had good response. And we are now planning to do our Christmas party as a virtual event. It's just going to not be very long, 2 hours, hour and a half on a Sunday morning, about 10 o'clock. And we're going to just do cookery demo, Christmas themed. We're going to look at a few products and we're going to play a game. And before the event takes place, we're going to send packages to the families' homes. And we're going to ask the younger children to develop Christmas crowns. And then we're going to hold a competition and hopefully send out a few prizes. One thing we noticed that was lacking was educational resources that we had for families that were around the region and we were unable to go and see, or they were unable to come and see us during the time of COVID. So we developed some videos for this. Our clinical nurse specialists have developed a video on blood spot teaching for the new patient with PKU. Of course, we would see them in person the first time, but we couldn't bring them back in if they needed further support. And it was difficult sometimes to get support into their homes. So we developed a video which they can be accessed through a YouTube link and onto our YouTube channel for the hospital. So we developed that. We've also developed a video on glucose and ketone monitoring. There's a little clip of it there in the corner. And future videos that I would like to create are on carbohydrate counting, protein counting, reading food labels, and making up emergency regimens. There's a bit of a waiting list now because other services have cottoned on to how valuable these videos can be in supporting families during the time of COVID. So not everything has been great during this time. I have found that there have been some issues and some lessons that I have learned. So there's definitely been an increase in emails that I receive, and there's been an increase in meetings. Now that all meetings are virtual, they can be booked back to back. You don't need to find rooms for them. So everything is a lot more intense, I find, working from home or working remotely even from the hospital. So everything is just a lot more intense. And when I work from home, I tend to put an increased pressure on myself to work. It's just to make sure everyone knows that I am working. I know they know that, but I put this pressure onto myself. When we first started, I didn't have all the equipment I needed. I had a laptop, but I didn't have a headset. And I was using my personal phone to do phone reviews. Fortunately, now I have been given access to a program called Jabba, Cisco Jabba, which allows you to make phone calls through your laptop. So that has helped there. I do manage a large team, about 10 people, and I have found it is quite difficult to manage the increased anxiety around COVID. Some people that had to be working in the hospital, they found that hard. Other people that had to work at home found that hard because they were isolated, especially if they were living on their own. And then you've also got the staff that have been working from home for quite a while now and then have to come back into the hospital, supporting people through that. So it's quite hard, and it's important to try keep up staff morale during this time. So I hold meetings for the staff to try and keep in contact with everyone and make sure everyone is doing okay. So lessons that I have learned throughout this time is that self-care is extremely important. I would find sometimes I would just sit at this computer and be in meetings and doing phone reviews and responding to emails and supporting families. And before I've known it, 6 hours has passed and I haven't taken time for my lunch, or I'll go and get my lunch and eat at the computer. And so I think it's really important that you take time away from the computer, make sure that you have your lunch break and that you have well-being checks, either with yourself or with someone you can speak with, and just make sure that you get time to exercise and time away and take care of yourself. It's really important. Thank you.
Thank you, VitaFlow, for having me to speak at this meeting today. COVID-19 changes, challenges and the future. This certainly has been one of the most challenging years. How we live changed overnight, and quite quickly how we deliver education and support to our metabolic patients. An overview of the centre where I work. First, the metabolic centre where I work and the team of dietitians who provide the service. Second, the service focus I have chosen, weaning on a low protein diet. And then to briefly look at the importance of having a weaning strategy, how our service was provided pre-COVID, and then how the service changed with the restrictions of COVID-19, and finally some thoughts on the future. The Royal Belfast Hospital for Sick Children is the regional centre for IMD in Northern Ireland. Northern Ireland has 6 counties, and travelling from County Fermanagh, for instance, or Derry, it takes 2 hours to the regional centre in Belfast. We have approximately 250 patients in our IMD dietetic caseload. IMD conditions, which are most prevalent, are PKU, MCAD, galactosemia. And at present, we have 107 PKU patients, on an average 6 newly diagnosed classical PKU patients per year. Our dietetic team consists of 1.4 whole-time equivalents in this period between March and October. We now have 2.2 whole-time equivalent dietitians, and this is spread through 4 staff. This includes a recent new post to help facilitate the expanded newborn screening programme, which commenced in Northern Ireland in March 2020. And this meant the start of weekend dietetic on-call service from March 2020. Funding for this post was to help provide a new on-call service for newborn screening. We have had the challenge of continuing to provide the dietetic IMD service during a pandemic, and also to train new staff in IMD, and we've had to cope with staff shortages. I want to focus on a patient group which requires intensive dietetic support, and during the weaning period on a low protein diet for PKU, HCU, MSUD and tyrosinemia indeed requires a large amount of dietetic time and resources. The weaning process is important in any child's development, as a baby makes a transition from solely breast or infant formula to include other food and drinks. And this can have far-reaching effects on eating behaviour and health. But with a metabolic condition, it forms a knowledge base used for a lifelong therapeutic diet. So time invested now will reap benefit for years later. This study by Evans et al., looking at mealtime anxiety and coping behaviour in parents and children during the weaning in PKU, just reflects how well probably our dietitians do. Mothers of PKU cope well comparable to control groups, but This period of time between 12 to 18 months, mothers feel more stressed, and it coincides with the introduction of second stage protein substitute, raised Phe levels, teething illness, and children developing their own independence. But by 2 years, mothers reported similar levels again of anxiety and stress as the control mothers. So it is vital that parents are educated and continue to be supported through this difficult time. So considerations and challenges which are unique to the low protein diet with patients, for instance, of PKU, are the measuring and exchanges, the encouraging the low protein foods, and the introduction of the second stage protein substitute. And Alex Pinto et al. In his study looking at weaning practices in PKU, which vary greatly between health professionals in Europe, recommended that we must identify an effective weaning strategy. And the weaning strategy really is to reduce the burden on carers and parents and to achieve acceptable dietary compliance and to ensure that we have optimal feeding development. And really, during and before COVID, we had an intensive education and support was provided between 4 and 18 months. They had regular sessions with the dietitian, and these were hospital-based. We did some home visits, but this was really more not standard. We would initially see between 4 to 6 weeks sessions. We had weekly telephone reviews with the blood results. The frequency of sessions will depend on the parent and the carer's ability, and it was essential to ensure that weaning is progressing. We offer clinical psychology support when required. And a weaning event is a huge part of our support. We organise weaning events every 9 to 12 months, and at these, each family and carer is encouraged to attend. It's informal, we meet in an hotel or an education centre, and usually this was one of the first opportunities for our families to meet with other families. Our clinical psychologist had a key part of this event as well, and she would do weaning and feeding activity. And it is always finished with a cookery demo. We use a weaning system, taking our families through the stages, and parents and carers are given education in manageable chunks. Reassurance is given at each stage rather than worrying too much about what lies ahead. We encourage them to enjoy each stage of weaning, and by the end they will be expert at feeding their baby a low protein diet. And we involve the parents, grandparents, childminders at each stage. So there's many aspects of education, and I think one of the key ones is encouraging our families to be organised and teaching cookery skills and establishing them on the second stage protein substitute. And we have found that our outcomes, we've had less problem with fussy eaters, better progression with the second stage protein substitute, improved engagement with organised events, and our local support group has become more active. We have a parent support for the new families, and we've established friendships, both with parents and the child as they grow up in the PKU community. And my concerns with COVID-19 really initially was how is this going to affect them? This generation, this year, these patients are going to really miss out. So there was less capacity to see them in the hospital. There was no longer able to have education events for the families on site or in the community. There was less support during this important stage in the PKU journey. And dietitians still must continue to lead the education and not let social media cause confusion. And we still had this requirement to carry on with a systematic approach to weaning. So the changes that we were able to do was to, first of all, we had to decrease the education support sessions for the patients at the hospital, and these went down to 2 to 3 monthly. Only one parent was able to, or adult was able to attend with child. We immediately had to move to increased time on telephone reviews, and we had to continue with the weekly blood test with the telephone review. But we invested some time in visual resources, and this really was what has helped us fill the gap. We've produced quite a number of YouTube videos as education tools, and we've had our first virtual cookery demo. Problems we encountered: home working. We had been using paper records, so we had to quite quickly move to electronic and dietetic records. And initially, our remote access at home was very poor on our own home laptops and desktops. We had only one mobile phone and one work laptop for home working, which was shared with 3 staff. There was very little training in digital technology, really none. And funding and availability of new equipment was very slow. It is improving now, and we're starting to get more laptops. And agreement for displaying videos on YouTube was a massive challenge, and we eventually got there. So the YouTube videos that we have produced, we have one with our clinical psychology on feeding and weaning a child with a metabolic condition, and this has been really useful. We've been able to share it even with some of the older children. We have a dietitian series on the stages of weaning on a low protein diet. And in these videos, we've brought together the different resources from the various companies on the low protein products, and the really good resource, the NSPKU, have produced so many things over the last 6 months as well. We've also had one of the companies produce weaning videos for cookery demo, part 1 through to 3, and VitaFlow have just done a virtual weaning session with us in Belfast this week, and now this has been edited and is available on YouTube for our families as well. We share these by email, the links, and we share them at particular stages slowly as they progress through weaning. And each of the videos are followed up with a telephone call, usually in the following week. So this is just some covers of some of the videos that we have for our families. The feedback from our families have that this has been helpful. They found it focus on one stage at a time is less daunting. They have felt supported and that we've actually put together videos for them, and they recognise the voices that they hear on the telephone are actually on the videos as well. That they can repeat viewing. Sometimes when they hear something in clinic, they forget it. But with this, they can repeat what they've seen. And they're able to share it with other friends and families and carers at convenient times. The future. We really hope to develop more video resources for various stages in the PKU journey. I would like to do one for starting school for packed lunches and perhaps the transition to secondary school, and more virtual group sessions for particular ages. The next one we would like to do is for between 6 and 10-year-olds. And then next year, I hope that we will be able to move back to more face-to-face reviews in education centres, events. Thank you.
So thanks very much to VitaFlow for inviting me to present today. I think, as you've just heard, I've just very, very recently retired, and I can say that retirement by COVID was maybe not quite as bad as you might think. I was a bit worried at the beginning. It would mean no parties, no nights out, which obviously it hasn't, but people have been very presentation today is on behalf of the other dietitians at the Royal Aberdeen Children's Hospital and how we manage our PKU children remotely, how we did it before and how we've slightly changed things. So this is the front of the Royal Aberdeen Children's Hospital. We're currently featuring in the second series of a Children's Hospital documentary on BBC Scotland, so everybody's been very excited about that. So we have within the Royal Aberdeen Children's Hospital 15 PKU children that we look after and about 15 other children on various metabolic diets. So in Scotland, we're organised a bit like an English region for metabolic services. There's a national metabolic service, and that's based in the central belt between Edinburgh and Glasgow. Some of you will know Dr. Cousins, so she's the lead physician for this. It's an adult and children's service. So I, until very recently, worked up in NHS Grampian, which is this grey bit at the top here, in the Children's Hospital in Aberdeen. And Aberdeen also covers, for paediatric services, the islands of Orkney and Shetland. And they have no paediatric services, so they are provided from Aberdeen. And just for a bit of context, if you want to go to Shetland, it's over 200 miles. And you either fly in a little plane with propellers, which takes about 40 minutes, or you take a great big ferry, which takes overnight to get to Shetland. And we have laboratory services in Aberdeen, but we also use the newborn screen lab in Glasgow for our Guthrie cards, our newborn spots, and for ongoing monitoring. And the service is an outreach service. So previously, we had outreach clinics from the consultants in Glasgow. And then within the last few months, the service has extended and there's now increased dietetic support as well, based in Edinburgh with Carolyn Dunlop, who many of you will know. But then what happened? Well, we all know what happened. Nicola told us we all had to stay at home. So we were just getting going with our enhanced metabolic service, and Nicola said we all had to stay at home, and I had to start to work at home for various reasons. So things did slightly change, but in many ways it wasn't anything new for us because we've always managed people quite remotely. So of our clinic of 15 PKUs, just as an example, 3 of them actually live in Shetland, and one of them lives right up here in Unst, which is as far away as you can get from anywhere in Britain. And so we've always had to manage people remotely. So when we've had a positive newborn screen, it's diagnosed obviously in Glasgow. The consultant down in the central belt liaises with the parents and ourselves. And in the past, we would have probably admitted at diagnosis, although we haven't always admitted. The second patient that we had with PKU had a positive screen in the middle of the most dreadful weather, and there were no planes or boats from Shetland for 2 days. And what we did, we had to send product up in the ferry. I had to go to the ferry terminal and put product up, and we got bloods sent down from Shetland on the ferry the next day because there was no other way we could do it. And so we actually did that child remotely. And we've been managing those children through telephone contact. I actually do a Shetland dietetic clinic twice a year for various specialist dietetic services, but we always saw the Shetland patients then. And we were lucky that we got funds for Shetland patients to come down for family days so that they didn't feel so isolated. They actually all know each other, so they do have a little mini support group. And I think probably if you go back, they were all related, unsurprisingly, in such a small population. So we had some things we were already using. We had what we call a metabolic phone. We also have a ketogenic phone, and that's a dedicated iPhone that one of the dietitians carries. And of course, what happened when I went home, I took the metabolic phone home with me, and I took on the kind of main role of managing PKU results. We were already using the phone to text PKU results, which we get by email from Glasgow. But we started to use it a little bit more, and families started to use it for queries about changes of prescription, requests for more blood spot cards, and so on and so forth. But what we realised, as we've just heard in the previous speaker, is that we don't have full electronic records yet, and our dietetic records are still paper-based. And so me changing things at home, even although I have a fully enabled laptop. It just was getting difficult with lots of emails asking people to update paper records. So we wondered if there was something we could use above and beyond the phone. And my colleague Tracy Cameron, who's much more IT savvy than I am, thought we could probably use a designated metabolic team to help support the way we manage these children. And that's what we did. So Tracy set up, this isn't quite how it looks, this is a mock-up, but on our file in our dedicated metabolic team, so it's only open to the metabolic dietitians at the Children's Hospital, although I'm just thinking we could actually open it up to the extended dietetic team if they were helping with these patients. We just record, when we get the sample back, the results, any changes to exchanges, any changes to protein substitute, anything else that we've said, perhaps to get mum to get the child weighed. If we've updated any home delivery service, we update it. And it means that any of us who are managing these patients can look in and out and record what's happening week by week. And we've actually found it incredibly useful. And it's really made it so much easier when people are working from home, because we've also had staff working from home because of our lack of office accommodation. So we feel it's provided an electronic record. Remember, Teams automatically saves changes, so it's quite easy to use. Definitely has facilitated our working from home, and easy for different dietitians all to contribute to the management of our PKU children. We have printed out the tables and added them to the notes at the moment when we've done virtual clinic reviews. And then I'm just going to mention a little bit about Near Me. Now, Near Me is the Scottish brand of Attends Anywhere. And Scotland was a bit further ahead, I think, for our obvious geographical reasons. We were certainly using Near Me within my department for ketogenic management and celiac reviews for some time. But it absolutely took off, as everybody knows, when COVID hit us. So in NHS Grampian, pre-COVID, there were about 300 consultations a week on the Near Me platform. And by April and May, it had gone up to 15,000. I mean, it is unbelievable. We were ready to go, but huge numbers of people started using it. And you can see this was a public engagement exercise carried out in June and July by the Scottish Health Service. And they looked at over 5,000 people and got their impressions and their comments on how Near Me was working or not working for them. And the benefits at that point were really quite similar for professionals and for patients. And it was very much around avoiding infection. You all remember at that time, nobody wanted to come to hospital. Everybody was really scared about coming to hospital. And it really was at that point the only way we could deliver any kind of close service to our patients other than phone calls. But these are the comments. They're very, very similar for patients and for health professionals. So that was the benefits, but probably what's more interesting, and people have referred to this a little earlier, is the barriers. You know, as time went on, we realised it's not the complete answer, both with technical issues. So the two words that we've started using in NHS Scotland are digital reluctance, which is, I think we've all had a bit of digital reluctance. I certainly have had some digital reluctance. Although interestingly, some colleagues who work in mental health have actually found it's been helpful for patients who perhaps don't like going out. They've actually preferred doing it this way. But that's an issue. Some people just don't want to do it. And then digital poverty. So although very high numbers of people have a smartphone, if you don't have broadband, you can actually spend a lot of money using up data on your phone, and people just won't want to do it. And that is essentially digital poverty. There has been quite a bit of money spent in Scotland, particularly around education, to try and alleviate that problem. But we have also found, as people have said, you just miss out. You do miss out on certain aspects. But dietetic clinics, not just in metabolic, but all our clinics became virtual overnight. For example, we have 300 children with diabetes, and all the new patients started to be taught all online, and that was a huge amount of work for the diabetes team. Our local and national MDT clinics became Near Me. So for metabolic, we would have the consultant and dietitian in Edinburgh, one of our dietitians and our local consultant in Aberdeen, and the patient at home. So we would do 3 or sometimes 4-way if I was at home, 4-way clinics. And then another really top tip, if you don't have this in your area, our community nursing team developed hubs in the community. So these were set up in community hospitals, some health centres, and we can get children heighted, weighted, we can get venous bloods done, we can get feeding tubes sorted out, they can do blood pressures, various other things for other people, and that's really allowed us to continue our service much more fully, because I'm sure a lot of you had problems getting heights and weights at the beginning. I think it works best if you know the family, and it is really useful to see the home surroundings, the medicines, the children running about. You can look at labels, they come and show you toys, they come and show you pets, and it does make you feel a little bit more part of the family. We have had one or two language difficulties. So we have in our PKU population a Syrian family who, although their English is actually very good, I think you lose the subtleties a bit on screen. And I think it is difficult to give emotional support. You just can't maybe see if somebody's a little bit tearful quite so easily. You can't pick up the subtle signs. So I think, as we've heard before, the blended approach is really going to be the way to go looking ahead. If anybody feels they want to learn more about ATTENDS anyway, or in Scotland near me, if you just Google near me, you get a lot of webinars, you get lots of training opportunities that have been developed in Scotland, which you might find helpful. Thank you very much.
Good morning. My name is Louise Robertson. I am a specialist dietitian in IMD working at the Queen Elizabeth Hospital in Birmingham, looking after adults. So thank you very much for asking me to talk today. I'm going to be talking about how we developed a video looking at different PKU products for our patients. So a little bit of background to our PKU service. So pre-COVID, we have about 150 adults with PKU. So we would run all-day PKU clinics, which ran 4 times a year. We would expect, although they don't always, the patients to attend every year for clinic. 1 year they would see the doctor and the dietitian, and the following year they would see the dietitian and nurse in the dietitian nurse-led clinic, and they would go back to seeing the doctor the following year. And as part of that clinic, we would have our resource room with all the reps in there from different companies. So to enhance their visit to the clinic, they would get to go and see all the different reps and learn about all the new products that are out there and be able to get samples. So during COVID, like everyone else, all our outpatient clinics stopped, and we moved very quickly to telephone clinics and then very quickly to video consultation clinics. And we use something called Video Connect for our consultations. I think we were one of the first teams to move onto video, and so we were ironing out some of the problems, such as at first there was only 2 connections, so the consultant could get on and the patient could get on, but the rest of the MD team was still trying to get on and we couldn't get there, so they had to open up more connections so we could all get on at the same time. But they, of course, were missing the opportunity to talk to the reps, the patients, missing out on that bit. So we had a think about what we could do, and we came up with an idea to make a video of all the different PKU products out there. So I went to patient information at the hospital and said, this is my idea. I really want to do a video, film it myself, edit it myself, and where can I put it for the patients to see? And of course, patient information said, no, Louise, you can't do your own video. You have to do it via the video department in the hospital. So contacted the video department, and they cost money to use them. They quoted me about £360 a day. So I was thinking, oh goodness, how am I going to fund this? So then I went to the companies and said, would you be able to provide a small amount of money? So I went through the charities. I asked the charities to send invoices out to the companies. Then I asked the companies to send me products that they would be showcasing if they were in the clinic, and a little bit of information so I could create a script. I then had to create a script, and then it had to go to communications at the hospital, and they had to approve it, and they made some small changes and then uploaded it onto the system. So because I had written the script, I was going to do the presentation of the video. I was happy to do that. I had it all in my mind. I had been organising it all. But of course, video was so stretched from doing lots of COVID videos that the only time they could fit the video in, filming in, was on one of my days off. So I had to ask Claire very nicely if she would do the presenting. So I kind of threw her in at the last minute. So here is Claire presenting, and also my assistant, our dietetic assistant, Sarah, went to help her as well. So they had a little practice in the morning together. They thought they'd show the products and run through it like that. When they got to the video suite, the video suite, they were told, right, you're going to stand here in this white room, you're just going to look at the camera and you're just going to read the auto cue. So they kind of stood there and read the auto cue through, and they also showed the products as well. And then when the video came back to us, they were not particularly happy with the video, because I couldn't even get a shot of them smiling. They didn't smile at all. They just were made to read through the scripts, and then they edited it together. And they also held up some of the products as well. And so the editing was panning between them, both talking and going through the products one by one. And I think we did it in alphabetical order to try and make it fair and equal with all the different companies. So when the video came back, this is Claire and Sarah hiding in their t-shirts. And of course, everybody hates seeing themselves and hearing themselves on a screen. So they weren't very happy with it, but I thought it was fine. It ran through all the products. It did the job, what it was meant to do. So before one of our clinics, we sent the products video out to our patients that were coming to the virtual clinic a week before, and said, please fill out this food diary, please watch this video, and then we can talk about it in your appointment. I haven't got any clips for you, but if you did want to see it, just let me know and I can send you the link. So even though we weren't totally happy with it, and really I felt like I could have done the video better myself, but never mind, all the feedback we got from the companies and from the patients was really positive. So I've picked out a few of the feedbacks here. So the first person said, this video has been very informative, as it means a lot to learn about the different companies and their products. The delivery by both presenters was very professional, with no bias towards any company or product, and it allowed the viewer to make up their own mind and to make further inquiries if necessary. And it was hard to see anything that needs to be improved by the nature of this video, as the nature was to inform the viewer of the products, and this brief was clearly achieved. So even though we were like, oh, actually, the patients did actually think it was quite a good video. Another feedback from a patient who knows about videos said, great with the video, it keeps us up to date. Obviously, I know how hard it is to be in front of the camera, so well done. So it was definitely a learning curve for Claire and for Sarah. This video is helpful and good to see the products and the summaries, especially the companies side by side. So they like to see what the range and all the different products that are out there. And then my third comment, one of the comments we got back, we did have a little giggle reading this because they hated the videos so much, Claire and Sarah, but this person said the videos are excellent quality and articulation as good as the BBC. I am in favour of the video impact, especially if it can be saved and played again as required. So the bit I've circled, the only addition I would like as an input are pictures of the metabolic team. This would enable patients to feel connected before they visited the clinic. And I think that's quite an important thing, even though they didn't like the video going to the patients. What the patients are seeing is they're seeing the dietitians, they're listening to their voices, they're making a connection with us before they come to clinic. So I think that is a good addition of these kind of videos, and what was talked about before, what Kathleen was saying. So in conclusion, we got good feedback from patients and companies. We got all the products into one video, so There was kind of no bias between the different companies. It's easily accessible for the patients because it's online. They can go back to it if they don't lose the link. It can be played again if they want to listen to something or go back to something a week later. And in theory, it should be a bit of time saved in their appointments because we don't need to go through all the products with them. They should have already kind of looked at that, so they can come to us with questions or ask for samples. Kind of on the other side, it was time consuming to make. I had to jump through a lot of hoops. I had to write a script. I had to send other people to go and do the filming. It was costly for us. We had to get some money to be able to pay for it. And would we repeat it in the future? At first, we were like, oh, it was very time consuming, and we weren't very happy with the end product. But with such good feedback from the companies, well, not the companies, from the patients themselves, then maybe we would. I think the products don't change that quickly, so we've been able to use it for at least 2 of our clinics so far. And it all depends what happens in the future as well. Then a little thought, could the reps do their own videos for us rather than us doing the videos? But if they did their own videos, it wouldn't be all in one, it would be different, and maybe they would sit on different websites. And would the patient then be bothered to go to 7 different places to watch each video? And if that happens, is that giving the opportunity for all the companies to be considered by the patient, or is it the patient's choice to only watch this video or only watch that video? Okay, thank you very much for listening.
So thank you very much for inviting me to speak today. My name is Sarah Bailey and I'm an adult IMD dietitian working in the All Wales service based in Cardiff in the Vale University Health Board in Cardiff. So I'd just like to spend a few minutes today talking about the changes and challenges experienced since the start of the pandemic. I'll give a brief overview of the service changes made before moving on to focus specifically on the service evaluations we undertook and the insights gained from these. I'll finish by reflecting on the barriers and challenges we faced, the lessons learned and the plan for the future. So as with everywhere else, as COVID hit us in early March, we initially cancelled all routine face-to-face activity. And during the first few frantic weeks, we responded to urgent queries and the albeit reduced number of blood spots that came through before establishing phone and video clinics. Several members of our MDT were redeployed to support with inpatient COVID care, and this, coupled with members of the team working remotely from home and changing hours to support childcare commitments, left quite a disbanded team. We soon established virtual MDTs, but the lack of access to the right home working equipment and the disparate working patterns left little opportunity for us to run joint clinics. In dietetics, we began by offering all patients who'd been due a clinic appointment a virtual appointment and left it with them to phone and book in. Uptake was poor, and we quickly, by May, moved to scheduling routine patients into fortnightly dietetic clinic slots, offering the option of phone or video. The consultants continued to run their weekly clinics by phone. Our CNS at the time was very proactive in leading us on a service-wide evaluation, which was distributed to all adult patients in the service, including the 50 national acute porphyria patients, lysosomal storage patients, PKU and general metabolic. This evaluation was well resourced, time and financial support from our patient quality and safety team and audit department. Amongst other objectives, the evaluation sought to establish satisfaction with services since the start of the pandemic and to scope how services were best designed for the future. In total, 297 surveys were sent out through a combination of electronic, online and postal. There was a 41% response rate. Notably, the online response rate was much higher, with 65% responding online and only 35% by mail. So with the global situation forcing us to make service changes, we saw this as a good opportunity to evaluate patient experience with the new dietetic clinic format. Given limited time and resources and the poor response rate seen from the service-wide postal surveys, the decision was made just to use an online evaluation tool at this stage. Everyone who attended virtual dietetic clinics over a 12-week period and had consented to email correspondence with us was invited to complete an anonymous online survey. This comprised of 10 questions and was estimated to take 3 minutes to complete. A cut-off date was given for the survey returns, and anything received after this date was not analysed in this round. The aim of this evaluation was to gather feedback on how the new virtual clinics compared to routine face-to-face appointments. It sought to scope out how patients would prefer to receive their care in the future. Patient-reported experience measures were included as well to gather opinion on the process of care. Questions looked for feedback on communication with the team, involvement in and understanding of decision-making and treatment planning. In the interest of time today, I've selected to discuss the most relevant outcomes for this session: patient perception of the virtual clinic platform and future service planning. So this slide, taken from the service-wide evaluation, shows the number of smartphone users alongside a breakdown of age group of respondents. 83% of patients use a smartphone, suggesting that this cohort of responders have access to online video consultation platforms. The age range of respondents is representative of the age range of the adult IMD service, with 50% of our cohort falling into the age 21 to 40 age category. And perhaps the younger demographic here goes a way to explaining the high percentage of smartphone usage, and it could just be the age that we're living in. So this slide then summarises the response from our dietetic evaluation and shows 50% of the patients rating the virtual appointments about the same in quality as a face-to-face appointment, with 33% of patients finding it not as good, and one patient who actually found it better than a face-to-face appointment. We then asked patients to give their reasons as to why they felt, if they had opted and selected, that they thought the virtual platform was better or about the same, why was that? And the main reason cited by 50% of responders was that it was more convenient not having to travel, followed by 33% selecting that it was more convenient so they could fit it around work commitments. Other free text comments received included, it made me feel more relaxed as I suffer from anxiety and struggle in crowds of people. No particular benefits, just as good. And another comment, you have ensured we can do our appointments over the phone and not have to come into hospital where it's more high risk. So when asked to give reasons as to why the virtual appointment may not have been as good as a face-to-face appointment, 42% of responders stated that they preferred to see someone in person, and 33% of patients preferred to see the dietitian and consultant at the same appointment. Free text comments included, although it's a great alternative and much easier to use, I sometimes prefer to travel to the hospital and see everyone in person. In the past 6 months, keeping in touch has been more frequent. I think in the future, face-to-face, as I find it more beneficial, but continuing the virtual contact thereafter when things are required. When asked how they would like to receive appointments in the future, the favoured format across both the service-wide and dietetic-only evaluations was face-to-face, selected by 42% and 52% of respondents respectively. Also ranking highly with the option of combined face-to-face and video outpatient appointments. Interestingly, none of the responders in the dietetic evaluation selected a preference for just phone or video consultations, and all preferred to have some element of face-to-face contact. So moving on there really to briefly discuss the challenges and barriers we faced. I think like many other centres, a lot of our challenges related to IT access and resources. We actually had no access to attend anywhere until August, although in dietetics we were fortunate enough to be able to activate as a video alternative in the interim. Home working was not widely possible for us in dietetics due to lack of IT resources, servers and electronic records. Again, as has been mentioned elsewhere, challenging queries around office space and social distancing, and the privacy requirements required for the video calls. We had to delay in receiving computer tablets, headsets and the screens we needed for video conferencing. Staffing-wise, in addition to a number of vacancies in the team, we also saw regular absences throughout the MDT from COVID self-isolation, testing, childcare, and it did leave a lot of staffing gaps. In reference to the evaluations, there are a number of limitations with both of these. The online-only approach of the dietetic evaluation at this stage does exclude those who did not have or did not want to correspond by email or have online access. And in neither evaluation have we been able to harness the opinion of non-responders. So lessons learned then, I think the value of good MDT communication, and I think we have in the past taken for granted how well it works and we're all in the same room, and just how organic it is, and it initially took us some time to get this working efficiently virtually. This has made us look at some of the reasons people might not be coming to clinic and some of the serial DNAs, and led us on to think about our approach for the future. I think overall the feedback suggests that the virtual platform is a good option, and here, as in many other centres, we have patients spread over a large geographical area, and there is a convenience in terms of travel and access with this. Furthermore, virtually, it is an excellent way of maintaining momentum and engagement between infrequent clinic visits, and might be useful as a blended approach. I think despite all of this, the majority of patients would still choose to receive some, if not all, of their care face-to-face. So just to finish then, looking towards the future, we are finally switching to use Attend Anywhere as a combined dietetic and consultant clinic format for routine appointments from January, and this will hopefully respond to some of the feedback we got of having the two, seeing the dietitian and consultant at the same time, and alongside this we'll continue to run urgent clinic activity face-to-face where safe to do so. To date, there's been little flex in our system for patients who've not attended face-to-face, and these evaluations again suggest we should endeavour to explore reasons behind serial non-attendance, and if we can, offer a more flexible approach for clinic format to best engage service users and to allow, to realise it's not one size fits all perhaps. In terms of evaluation, I plan to conduct a larger, better resource evaluation in April, so 1 year on, since everything changed. And at this point, it'd be really useful to try and combine both patient-reported experience measures with patient-reported outcome measures, and to see if there is a correlation between patient experience and outcomes. And I think I'm really keen at this time to look at how we can engage with non-responders and those with whom we don't communicate with via email, perhaps through some outreach sessions or focus groups. This is something that we'll be looking at. Thank you very much for your time today, and we look forward to the question session. Thank you.
Well, thank you very much indeed. We have some brilliant speakers there. Now, I'm going to ask Rachel if I can have my slides up, please. Many of you kindly completed a survey in the last 2 weeks looking at your experiences in COVID-19. So what I'm going to briefly take you through is the results of this survey before we do some questions and answers. I also have to remind everybody, we have had some very interesting presentations, so please submit your questions and we'll try and deal with these at the end. So if I can have the first slide, please. So one of the first questions that we asked in the survey was, what was the most common technology you all used to review patients? Now, we only gave you one option of asking the questions here, and certainly the majority of you said that you would use video consultations. Just under half said you would use telephone consultations, and a small number of you said you would use email consultations as your form of communicating with your patients. If I can have the next slide. We asked about your changes in working practice. You know, what was you doing differently? So what we've done on this slide is divided the answers into day-to-day clinical practice, education for patients, and health professional working. So if we look at the day-to-day clinical practice, well, this is evident that many of us have had to go onto patient video calls. We've got a little bit more flexibility in the way that we see our patients, and we can see them outside clinic times. There is more work associated in the roll-up to clinics, that we may be sending out questionnaires, we may be sending out dietary assessment forms, requesting heights and weights. So that is taking a little bit more time. And the way that we issue clinical food samples has changed. We need to organise that these directly go to the homes, and we need the companies to work with us on this to give us the ability to do this. As far as education for patients is concerned, you can see from the presentations that we've had already how flexible people have been on this. And I'm not going to go through the types of educational things that you are doing right now, but incredibly innovative. And then if we look at health professional working, again, we've had to change the way that we operate. And when we're working with our colleagues, we're obviously minimising the amount of time that we spend with each other so we don't pass on COVID-19 infections. So we've had to adjust to virtual team working, and that has had its challenges. And of course, we've had centres have introduced electronic records for the first time, and that's got to be good news. Next slide, please. We asked you all, if you had a choice, would you continue with remote consultations as part of your regular service? And 36 of you in total responded to this questionnaire, and interestingly, all of you agreed on this. The answer was yes, you would like to continue, but partially, in combination with face-to-face consultations. Next slide, please. We then asked about the tools necessary to improve the patients' and parents' experience of remote consultations. Again, tried to divide the answers into answers from patients, health professionals, and what we needed for data collection. And certainly there was a lot of overlap between the tools necessary between patients and health professionals. We all wanted better access to technology, the computers, the tablets, the telephones we use. Easy technology that works on all devices. Reliable and fast internet access, how often that will fail on us. And more technology training, particularly the person who is giving this presentation right now. When it comes to the health professionals directly, one of the things that many of you asked for was actually to have more professional time or admin time allocated to explain how to use the technology when you're about to see a patient. Of course, this all takes extra time, and some people do need a lot of help. That we need access to web cameras, easier to log on systems, which can cause a lot of frustration. And certainly for the people who are working in the dietetic departments, we all know that often dietetic departments are very small with only a small number of rooms, and we need more dietetic rooms for confidential video consultations. As far as data collection is concerned, we need a little bit more in the way of extra databases and standard patient feedback surveys, and this is something perhaps we can discuss very shortly. We asked if you assessed parent or patient satisfaction about remote consultations. About a third of you said yes, but very informally, just how did this work for you? Just over 20% said yes, and you would do this in a very formal way. And the question is, should we be doing this automatically with all our patients? And around about 40% of us said no, we wouldn't assess what people thought of our remote consultations. Next slide, please. We asked a question about any difficulties in obtaining routine biochemical monitoring for patients. Only a tiny percentage of you said that you couldn't obtain your routine samples. Thankfully, the majority of you, 70%, said yes, you can, and you can obtain this via your usual hospital site. Around about 30% said yes, you can, but this was from using satellite facilities, so things such as district general hospitals, GP surgeries, drive-in facilities for bloods, which I thought really quite innovative, and using community nurses services. The issues that people identified was things like samples just limited to urgent ones only. One centre reported having reduced phenylalanine analysis to certain specific days only, and difficulties with arranging samples at district general hospitals and sometimes within GP practices. And people's experiences would vary between good and not so good. Next slide, please. Now, this is an area that we was particularly interested in. What are you doing for height and weight measurements? How are you working around this? And most of the adult and paediatric dietitians were relying either on parents or patients weighing themselves at home using whatever equipment they had at home or they could borrow from somewhere else. It may or may not be reliable, but this is the best we can do. Some dietetic departments in the paediatric world would loan baby scales if they have a very vulnerable baby and they was worried about the weight for. Some people talked about using the BDA paediatric group guidance on measuring height and weight. And this is some very pragmatic information if you haven't already read this. Some people are able to do this routinely within the clinics or in the GP surgeries. And one of the things that I thought was particularly innovative, again, was driving clinics for heights and weights. And this is where a temporary establishment had been set up. People went to the driving clinic, was weighed either by a diet assistant or a nurse and heighted, and then the information would be put onto a computer and sent back to the referring dietitian. So very innovative in that way. Next slide, please. Now, we asked about safeguarding or child protection concerns. Is this a worry for you? Now, we didn't distinguish between paediatric and adult responses here, and I think this probably influenced the reply. Round about 40% of you said yes, you did have concerns, and 60% said no. Next slide, please. But if we look at the specific concerns that people said they had, these were interesting. Some commented that child safeguarding teams recommended that children must be present during any remote consultations, so at least the medics or ourselves could get some idea about the well-being of the child. And so it's important to see, have you got that child in front of you? When you have concerns, sometimes it's difficult to access some families. You can never get them by telephone, or some families seem to always be able to avoid video contact. They can't use the technology. Certainly with some families, there's been an inability to weigh or measure or observe children. People may not have scales at home. And this really always sets the alarm bells ringing, because it's when children are losing weight. This will maybe give you some idea there may be some issues going on. The inability to do home visits to assess conditions, people highlighted as a problem. Social workers may be unable to go into the homes, again, to assess the conditions. And somebody even reported there was an increase in family breakups. Now, I don't know what the national position is on family breakups with COVID-19, but that is something that's worth exploring. Next slide, please. Everybody was asked to discuss some of the positives associated with remote consultations. And again, these have been divided into what dietitians perceive are the advantages for patients and what they perceive as the advantages for themselves. So if we concentrate on the advantages for patients first, that obviously when patients are reviewed remotely at home, hopefully the environment is much more friendly and less anxious. The appointments are often much more efficient, often on time. There's not a lot of waiting time associated with them, and we can be much more flexible. There's greater ability to have shorter consultations, have them more focused but more frequent. Interestingly, many people reported that the do not attend appointments had gone right down. You're more able to get a full clinic. Some of you reported that you've been able to open up communication channels with some patients maybe who'd been lost to follow up previously had come back into fruition and was happier to talk online. Many people talked about the advantages in problem solving, that you could talk to somebody virtually online, you could solve problems with protein substitute intake because you could see a child taking it. You could teach people how to look at food labels. You could look at any particular problems with the way that they was making up products. So that was definitely a positive. Easy to teach the extended family online, grandparents, aunties, uncles. There was less time and cost associated with travel, less stress associated with the travel, so that would alleviate the burden for the families. Less time off school for the children and generally lower patient anxiety. But that was our perceptions of this. For the dietitians, what did we say? That we were very happy to work at home, that we was often spent more time doing clinical work, so we had less time travelling. It was felt that we were seeing that more patients were responsive, and some people said that they were more likely to engage teenagers in transition processes, whereas others said it was actually more difficult. Next slide, please. So let's look at the negatives with remote consultations. Again, we've divided this into patient disadvantage and dietitian disadvantage, and please note there are a lot more dietetic disadvantages than patient disadvantages that we perceive with remote consultations. Certainly patients like direct face-to-face, particularly with the medics. They find this reassuring. It's good to be told that everything really is okay. It's harder to believe when you're doing it on a remote consultation. Obviously, we've got technology phobia. We've all got a little bit of that. And certainly it was commented it may be inappropriate for adults with learning difficulties to do the remote consultations. As far as the disadvantages was concerned with the professionals, with the dietitians, people identified that multi-agency video calls were difficult. Patients often say you cannot see everybody online at any one time, and then you may have one person who has a little bit of equipment failure. Certainly when doing teaching sessions with schools and nurseries, and there's a number of people together, it may not be possible to see that everybody is watching, listening, asking questions, taking everything in on board. Right now, we can't see what people are doing right now. You're probably all eating your lunch, but it is an issue that you cannot always get that feedback with video work. People often commented that there are issues that were difficult to explain online, issues that was difficult to engage the mental health of people, their emotions, how they were feeling, harder to build a rapport with people, and certainly Kathleen discussed some of this in her presentation. Harder to engage children. It's harder to do teaching sessions with children. How do you keep them entertained for a 30-minute or a 60-minute session? I've yet to learn about this. The worries is that some people don't always take appointments seriously. They may not be ready for appointments. They may be driving in the car when it's their appointment time and they can't maybe focus on the road and you at the same time. It's more difficult for product tasting, samples, showing displays. Running events is a little bit challenging. And I think something very importantly is people identified they had less professional support. It can be quite a lonely business working from home, and sometimes you hope you're doing a good job, but you have no idea, and you've got nobody there who is watching out for you. And the final slide, please. And this is really just to end my presentation. We certainly hope that we have an end to COVID-19 shortly. Yes, we do want to take some of the learnings from COVID-19 and put them all into our practice at the end of everything. But I think we need to pick and choose and make sure that our patients get the right kind of care and the right kind of direct care as well. Now, before I bring in all the speakers from the last hour and 20 minutes or so, what we've got is a poll for you today. And if I can have the poll question up online, please. Do you feel stressed under COVID conditions? Interestingly, 75% are saying yes and 24% saying no. So I think 76% are saying yes. So I think that's an incredibly interesting result, and that may be worth a little bit of debate now. So if I can have all the speakers online, and let's take some questions for everybody right now. Thank you, Camille. You're up and running. Thank you, Anne. And we've got absolutely everybody, and I've got masses of questions for you, and but well done, absolutely everybody. And I think if we can quickly, we are behind time, of course. We were lovely on time, but we've ruined everything. But there we go. And but firstly, I've got questions for you all, and the concerns, let's just take the concern about dietitians feeling stressed. And Louise, I think you'll be great on this. What tips have you got for dietitians to try and reduce the stress levels?
Oh, with working from home.
Yeah.
I suppose all the general stuff, isn't it? Making sure you're taking your lunch breaks, getting up, moving around, doing the exercises at your desk. My colleague Claire, she loves all this kind of things, and she has books in the office on that 4-pillar plan by one of the doctors, and we're always doing the desk exercises as well, or getting up and doing some exercise, but talking to each other as well.
Yeah, I was going to say, how well do you support each other within the team? You know, do you have daily contact, team meetings? How do you do that?
Well, we actually, because we're a small team and there's only 3 dietitians and we sit in our office, but we're all part-time, so we have never really worked from home. We had the opportunity to stay within the office, so we've been very lucky. But even within our team, we don't see each other all the time. And we've recently introduced a team meeting that we do every month now to discuss things. And that really helps us as well to discuss anything that's going on.
Okay, that's lovely, Louise. Now, Camille, I'm going to come to you next. And we've got a question here from Anne about the dangers of remote working and child protection. And in terms of what extra measures have you put in place in obviously not to give us specific examples of patient problems, but what extra measures have you put in place to try and protect children with this remote working?
Well, as an MDT, we set up a meeting every 2 weeks called a COVID meeting, where we discussed all the different rules or regulations that were coming in from the government. But part of that meeting, we also had a section for child protection issues and concerns that we had. So we would address them together as a team and bring in our child protection team in the hospital to help us address those. And we have had cases where we've had to do a lot more consulting that team and raising concerns with schools and GP surgeries about patients that we're having difficulties with. And that has gone up during this time period. And I guess for remote working for dietitian safety, we have developed a rota for the whole department so everyone knows where everyone is working. So if they're in the hospital or if they're working from home or if they're working off site in another hospital, because we have had to branch out to private hospitals to do clinics there for face-to-face to allow more space within the waiting areas. So it's just making sure that we know where all our staff is. And I do have regular contacts with my whole team. So we are quite on top. We will notice if someone is not answering emails or is there an issue. So everyone's a bit wary and aware of everyone's situation as well. Like, are they at home on their own? Do they have family? So we do keep I'm not saying a close eye, it's not like a monitoring thing, but just we're looking out for each other.
Yeah. And one of the things that you talked about was the importance of the regular events with families, and that is something that I think some of the families are struggling with, the lack of contact with each other. And we've got a two-part sort of question here about, I mean, how do you engage children online, and when you're doing online activities, and Anne's come up with a question about there have been a lot of innovative things that have been done, and maybe Camille will want to come in on this in terms of patient education. But how can we further improve these, and how can we make these available for everybody?
Well, I think engaging children can be difficult, as you mentioned, Anita. That's why with the Christmas party we're hoping to do in the next few weeks is we're sending a package of activities in it to the house beforehand so they can do those before, and then children often quite like to show what they've made and what they've done. So hopefully we're going to get some engagement that way. I know from experience, there's like my daughter does not do very well on her Zoom ballet class. I think she participates for about 2 minutes and then does her own thing. So it can be difficult. So.
And what about yourself?
Well, I suppose one of my concerns is the actually meeting of children, each other, really, and building friendships. And a lot of the events actually enable that. And really, so far, really, we haven't been able to do that. And I think if this is going to go on for much longer, we really do need to look at how we're going to do that, how we get actually the children to actually speak to each other and the families to speak to each other. So I think that's a challenge. And I think that's probably something we need to do as a group of dietitians, probably. And hopefully we will be able to connect on that probably in our EIMDG meeting.
Yeah, that's lovely. And Sarah, the patient feedback, do you think that's something that we should all be doing routinely when we do? Do you think we should have some sort of automatic at the end of any consultation, some feedback mechanism, and we're just not gauging what people think about the process that we've just gone through?
I think in an ideal world that would be fantastic. I think we all know from a practical and resources point of view that that's really hugely the challenge. I think that this, because we were forced into this change of practice, it just provided an ideal opportunity for us to evaluate what patients thought. There's certainly room for us all, perhaps as a group, to I think somebody suggested it on the feedback already, about coordinating an approach, coordinating what we're asking patients, coming up with something collectively and almost sharing the workload from that perspective as a sort of whole scale like evaluation.
Yeah, okay. And we're getting lots and lots of comments. So just one question that's come in from Marjorie about, does anybody use an electronic food diary that's been validated? I'll answer that one for you. And Sharon Evans has just finished a validated food diary, food frequency diary, and which will be available shortly. And we hope that it will be available electronically. So there will be one of those available. We've got lots of comments here. Marjorie has developed a health and wellbeing hub to help, well, Marjorie Hospital has developed, I'm sure Marjorie's contributed, a health and wellbeing hub to help people who are under stress. And so that is really good. Barbara likes the idea of sending out packages to people for the events, and I know personally that the patients absolutely love that. We've been doing that for some time, of course, and they love getting the package, and also it means that they're a little bit obliged to come online and use that package. So it does actually help. Just in terms, a final question I want to ask, and then it is lunchtime, and it's a question to you all. It's about patient engagement, and because we've got adult and paediatric dietitians on here, and I'm going to go to, again, Louise and Sarah first, and then back to Camille and Anne. How do you find the patient engagement better, worse, or the same than pre-COVID? Who's going to go first, Louise?
Yes, okay. We find it similar, as in DNA rates, especially for the PKU patients, they still forget that they've got a video consultation, or you phone them up and they're like, oh yeah, was that today? So I think once you get them there and they're online and they see how good it is online, it's good, but we still got the problem of people forgetting their appointments.
And what about you, Sarah?
I think it's a similar experience to Louise. However, there have been some patients where, whether the lockdown has almost provided them with like a natural period of reflection, and we have actually found that people that we've previously really struggled to engage with have actually come back to us. I think what's happened in the past as well is where we have had people who haven't attended clinics or serial DNAs that maybe have been chased by our clinic coordinators, but not by ourselves, whereas we are doing that now as dietitians. And perhaps because it's us on the end of the phone that's being able to speak to these patients and perhaps maybe actually bring them back in, we have had a few that have come back to us during this time, which we maybe weren't expecting to happen.
And Kathleen's just come back on my view. Kathleen, you've been hiding. And so
I wasn't hiding.
Yeah, you've just come back on my view. Mm-hmm. And Kathleen, I'm not going to let you go away after 43 years without a question. How have you found engagement, better or worse than before?
I think we found it as good, or if anything, a bit better. I think patients, were absolutely no problem. In fact, they really, really wanted to speak to you. And I felt some patients, I was providing a whole family support system, and it was fine. I was at home. I could give a little bit more time to them. But I personally didn't have a new patient. And I think a new patient, I would really worry that you don't really get to know them the same way, and it's just harder to build relationships. But I don't know, maybe somebody who's had new patients can comment on that.
Yeah. And any final comment then to Camille and Anne on that about new patients?
Yeah, well, we have had I think 6 new patients, and I think we've brought them to the hospital to ensure that we have had that engagement with them, because I think it's key, because it's the start of their journey, and it really is important that they didn't miss out there. So I think we actually did what we really felt was necessary for our new patients, and did see them. And then we've obviously had a lot of telephone contact as we would. So I don't really think they've missed out, but I do think they've missed out in meeting other families. And I think that's where I would have a bit of a concern for them. But our teenagers, I feel they have engaged better. They've been home from school during lockdown, and we're glad to speak to somebody. So I think they probably did better.
And Camille, any just final things, and then we'll end the session.
No, I echo what Anne has said. All our new patients, we have brought them in for at least 2 face-to-face consultations when able to in the beginning, and then after that moved over to video and phone support. But overall, I would say I think our engagement with patients has increased, and I know my dietetic clinic is definitely being utilized a lot better now that I have access to video consultations.
That is lovely. Louise, and then we must go. Yeah.
Sorry. One last comment, just thinking about everyone doing their own webinars and doing their own videos. And I watched the BDA webinar last night on making webinars by Marianne Williams, who's done all the IBS webinars, low FODMAP webinars, which is just branded with NHS. And instead of us all doing our own videos, wouldn't it be great if we had central videos that are provided, so that it's all in one place and we're not all doing the same things.
Louise, I couldn't agree more with that. I think it is important to share facilities. We're all working 10 to the dozen, so I think that really is important, and I think that's an important final message. Well, thank you everybody. It is time to a really good discussion, lots of comments as a result of this. Time to hand back over to Rachel.
Thank you very much, and thank you to everybody that's contributed this morning. There's been lots of discussion too, which has been really fantastic.